taping?
Yes. Okay. All right. So, you guys, we are going to do our COP simulation lab here today. And this is your patient. This is Mrs. Young. So what we're going to do is I'm going to give you a little bit of background information about her, which is on the sheet. You guys can ask any additional questions that you think you might want information about or want to know about her. Then I want you to go ahead and pretend, obviously your vital signs are already up there, but assume like you have just gotten a report on Mrs. Young at shift change, and so you're going to go in, you're going to do your vitals, you're going to do your assessments. And after that, we'll go ahead and I'll kind of pause the video here for a minute. I'll let you guys sort of analyze your blood gases, interpretations, things like that. On the back side, I want you guys to kind of think about what are your priority nursing interventions. What are you, based on what you have gathered about Mrs. Young, what are you going to do? And the big question is, why? Okay, we'll talk about those there for a minute. Then actually we're going to skip the S-bar for right now. We're going to go to the documentation piece. Okay, we'll talk a little bit about documentation. One of the other things that I do in addition to being a nurse is I work as an expert nurse witness for medical malpractice cases involving OB.
Oh, wow.
Whoa. So I am very, very, very in tune with documentation. And I'll give you guys a couple little tips here.
Super.
Just to kind of keep in the back of your mind. Hopefully you will never ever have to be in that situation, but more than likely you will. And then we're going to end with a game. Ooh, with S-bar, because everybody loves talking to doctors, right? Yeah, I understand. Okay, so Mrs. Young, she was admitted last night from the ED with shortness of breath. She's coughing. She's got a very productive cough. She's got a very thick sputum. She doesn't have any allergies. She does, however, have a 20-year history of COPD. Her medications are albuterol inhaler, Flovent inhaler, and she does sometimes use oxygen at home, PRN. Is there any other information that you guys might want to know about?
How many liters does she usually use at home?
She usually uses 1 to 2.
And how often does she use her inhaler?
She is supposed to be using it every 4 to 6 hours. And Flovent is her once a day. But she says she ran out of those recently and hasn't been able to get to the pharmacy to get those refilled.
Okay. Does she live alone?
Her daughter stops in every once in a while and checks on her.
Okay.
And her daughter brought her into the ED last night.
COPD is the only thing she has.
Right now, yeah. Not bad for a 60-year-old woman, huh?
No. Does she have a history of smoking?
She quit about 10 years ago.
What was her packs?
1.5 to 2 a day.
Have we done any labs besides the ABG?
That's it for right now.
Okay. Has she had a chest x-ray?
Nope.
Okay.
The ED basically just said, yeah, she's in trouble, and brought her upstairs here to us.
Has the doctor prescribed the albuterol and the Flovent for her in-hospital stay?
Not yet. The doctor has not made his rounds.
Okay. Has she used oxygen since she's been here?
No. We just kind of tucked her in for the night, and she said she was doing better. Anything else you can think of?
This is sputum sample
What color is it? She's been coughing up thick yellow.
So she's not feeling shortness of air now.
Last time I checked on her a couple hours ago, she said she was fine.
That sounds really cool.
Is she in pain?
She doesn't say she's in pain. No, she's been really cool.
Okay.
I mean, has it been asked?
Has the doctor said anything about her high blood pressure? Her high blood pressure?
Oh, I didn't think it was high.
Okay.
All right.
Well, you guys have a great day.
Thanks, you too.
I'm gonna go to bed.
Alright, good night.
Get out of here.
And believe me, I know that sounds weird. You will get a report like that.
All the time.
And so, even though you're thinking of these things to ask, oh yeah, I checked on her a few hours ago. She was fine. Yeah, exactly.
She's done.
I promise she's still alive for this scenario. But when you think about those things, those are some of the things that help you prioritize which patients you're going to get in to see first and which ones might be able to wait a little bit longer. So if you have somebody admitted with this type of a diagnosis and the nurse going out says, oh yeah, I checked on her a few hours ago, I'd be like, oh,
You're the first person I need to see.
you are the first person I need to see.
Yeah.
Exactly.
Nobody knows how you're doing.
Exactly. All right, so I'll let you guys go ahead and do your vitals and your assessments.
So would you want us to actually do the vitals or take those with
You can go ahead and take them off the screen. That's fine.
Okay, that's fine.
Because
Okay.
I'm assuming
Is there
that you
a
guys
temp?
know how to, the temp, yes, good
Does she
question.
have an actual, like, if I listen, there's lung sounds?
There, yes. Her temp is 99.5.
Was that oral?
Oral, yes.
Good morning.
She doesn't really talk back a lot.
That's nice.
But, yeah. She likes to keep to herself.
Does this one actually speak?
No, this one doesn't.
They don't really like me to hear, like,
You really can?
Is it cool?
Do you
can
feel
I hear
pulse?
from the back too?
Oh, yeah.
Okay.
All right.
I'm gonna have you turn to your side.
Yep, and you can ask for help and
Oh, what is this?
these are just some of the when they do some other types
Like
of
right
trach
here,
here.
isn't it?
Mhm.
What would I listen to in here? Because there's this.
It's, you know, you may not necessarily hear them very well on the back. Try up top
Okay.
and then try right in here.
How does she get that? Grab it door.
Yeah, she can get up on her own.
Okay.
She's fine.
No
Yep.
walker?
Nope.
Do you have your fluids in you?
Not yet.
Like it. Yeah, we should get some fluids going. Blood pressure.
I'm not sure.
You're like an order that.
Get the doctor.
It's right here.
It's kind of heavy.
It's amazing how heavy these mannequins actually are.
I like this one a lot better than the one that talks.
That one actually, when I saw it the first time and it talked back, it really kind of freaked me out a little bit. Because I'm not used to having the mannequin talk back to me.
Yeah, the ones in the sim lab across. It's always like the meanest person too.
That's
I
what
feel
I love.
horrible.
Yeah, I agree with you.
Yeah.
Pain
Just
is so bad.
Yeah.
Where do you do it at?
Just kind of right on the side.
Yeah, I was like listening to like that side, and you can hear the popping. So grab hormones. We got some crackles.
I don't want to listen on her.
Mm-hmm.
Can you feel pulses too?
I can hear it.
Now you should be able to get pulses, but
Ooh, there was a bug that flew out of here.
Oh, Lord.
Are you sure it wasn't just
Weird.
like a...
Yeah, it's right there.
That's not a bug. That's just
Oh,
a fuzzy.
okay.
Okay.
Don't do that to me.
I don't know if you can feel pulses.
It's weird when they don't talk back because then I feel rude for not talking to them.
No edema down here, guys.
No edema. That's good.
No,
Correct.
No.
Her skin is cool, dry, pink.
Do we
Mucous
have a
membranes are moist.
Do we have a cap refill
Half refill's about 3.
Is she usually, is she a CO2 retainer or?
They haven't done those in a while.
Okay.
She hasn't been real compliant with seeing her
So you do some
respiratory doctor.
Yeah, there's an option for her 86. I don't know if I should, do I need to get it to 92 or do I need to?
Well, yeah,
get it to
her
100?
CO2 is 35.
I think we should put some oxygen in it.
I think we should get some fluids running.
I agree. Will it hurt her blood pressure? Yep.
Yeah.
I'd like to have the doctor in to see it.
I'd like to get some labs drawn as well.
Yes. And have her at home meds be continued here.
And maybe we need to change your meds. It's not, maybe that Fovent is once a day, maybe that's not enough for her.
Well, and then culture and antibiotics.
Yeah.
I would like a chest x-ray.
Yeah, that's true. Maybe she has some pneumonia.
We have
on
so
top of
much
this.
stuff we
Oh my
You're
goodness.
demanding.
You are very demanding. Okay.
The doctor is the first patient.
All right. Did everybody get to listen?
No, I didn't.
Okay.
Okay, do you guys concur with the crackles and diminished?
I definitely heard diminished. I didn't flip her, but
The crackle was probably more backside.
yeah, it was like her. Yeah.
Crackling.
She's also in respiratory acidosis.
Yep. Uncompensated.
Uncompensated. Yep. Do we get to call the doctor or you the doctor?
Mm-hmm.
Which isn't like hyperventilation. Isn't that?
Isn't that where you breathe?
Isn't that-
Acidosis is when
You're taking in too much. I know, but what stuff? Like what
You breathe
diagnosis?
in it back, don't you?
That's how you get rid of it. Yes.
that's for alkalosis. Acidosis is when you
Okay. Now I want you guys to listen
not
again.
taking in enough CO2.
Okay.
Okay.
Listen again.
I want you guys to listen again too.
Okay.
Well, you can give syrup.
Now she's really complaining that she's having a hard time catching her breath.
Or heart rate's 1.6.
Yeah.
Oh. That's right. You're like super excited.
I hope nobody has ear germs.
Sorry.
I took a shower before I came here.
I'm fine. I'm clean.
You're the least cleanest person in this room. She's the girl with bronchitis. So. Maybe we should listen to your one. She's like, I'm fine.
I'm fine now after my steroid inhaler. I'm good. I'm kosher. Yesterday not so kosher. Today.
If you would have coughed one more time, I'd be like, get out. You can
Dude,
listen
I
to
know.
class in the
it was
hallway.
So
That's
bad.
right.
Sorry. I broke her.
Yeah, it's okay. She doesn't have a trach.
I feel like we're
Oh,
getting ready to do
people before.
CPR to put the board under.
Or disconnect you. Before they lay her down.
You need to have your hair washed.
Did you hear?
And were you guys able to pick anything up on her heart rate?
It sounds like it's like it's like not S1 S2 S1 S2.
Okay.
Sounds a little.
So once you listen to it and looking at your monitor,
Hold on. Yeah. Look at it. She's got some hardcore tacky.
Does she have
Was it the sawtooth?
Is she
Does
in
she
like,
have?
is she an AFib? Is that AFib?
It looks
Irregular.
exactly.
It's very regular.
You
You guys
guys
got
got
it
it.
down.
Excellent.
Uh-oh.
And one, with these mannequins and also on real people, you can't shut their heart off, obviously,
Right.
to listen
Her
to lung
wheezing is
sounds,
so bad.
because sometimes their heart sounds are a lot more
Really
prominent.
And AFib sounds like a gallop, like
It
a
does.
horse.
It's
does.
a very strange
Mhm.
sound.
Is that does she
So
have a
even
history?
though you may not exactly know by listening what it is without looking at your monitor, you know it's not normal.
Yeah.
Correct.
So we need to get an EKG. We need to possibly get her started on some anticoagulant. Well, can we take the EKG from the? She's on telly, so can we take it from there?
Mhm.
Okay.
Yep.
Yeah. Doctor, maybe we need some dialysis.
Fix that.
Doctor needs to come
Cardizem.
in here.
Yeah, I guess it's like, we can't really do a whole.
Stat, we need a doctor. Does she have a history of AFib?
She does, but yeah, not for that long. Just about the last 2 or 3 years.
So they didn't diagnose her because.
She just didn't want to take any more medicine.
Her wheeze is like.
Yeah. Did you get to listen to both of them?
Yep.
Yep. Okay. All right. I'm going to pause this for a second. Okay. So, yes, now we are. Okay. So, what are some of your nursing interventions that you guys are going to want to do?
First, slap some O2 on her.
Okay.
Raise the head of the bed.
Perfect. Here's a big hint for you guys for NCLEX testing.
Oh,
Ooh. One of your first nursing interventions. What is she right now? She's flat.
She's
yeah, she's
fine.
not getting good respiratory.
Anybody who can't breathe and is short of breath, what are you going to do? Set them up. Okay. What's another position that you could put her in to help her breathe?
The tripod, have her lean over the
Have her
table.
lean over that table. You could do some maybe coaching with her breathing, doing that pursed
I
lip
mean, and making
breathing.
sure she's actually bending at the waist
Mhm.
so that she's getting that good deep
Yep.
breath. Breathing.
Because a lot of times you can make them more comfortable and help some of these problems by repositioning your patient.
Okay.
And that's, I don't know why NCLEX is huge on what's the first thing you're going to do, you're going to reposition your patient.
But wouldn't that be? Isn't that just because it's like non-invasive?
Right.
It's like something
It's
super
something
simple.
super simple, but it makes a huge
I mean, it makes, like, I know, like, when someone gets sick, you know, like, even me, I have to put a couple pillows under my head at night, you know, so I'm not having problems breathing.
Absolutely.
It's just kind of but it's one of those things we don't necessarily think
Mhm.
of.
Yep. Okay, so we're going to reposition her. We're going to put oxygen on her. Okay.
Mhm.
I want to get fluids running.
Right, so we're going to get some IV access. Call the physician. Excellent.
Get her daughter here so
Her
we
daughter
can do
here.
some education.
Yeah.
Maybe see if the pharmacy she's at can deliver her meds to her house.
And even like reviewing medications, like compliance.
Right.
Talking about like, is there something about it, like aside from the amount you're getting, like
Absolutely.
is it not easy for you to use and things.
And somebody had mentioned this earlier.
Want to get labs done.
Labs.
Mhm.
Chest X-ray.
Sputum.
Mhm.
EKG,
Excellent. And who's the other one person that you are really going to want to call?
social.
Respiratory therapy.
Respiratory therapy, exactly. They are some of your best friends
Yeah.
ever. Anytime I get in trouble, I'm like, oh, hey, come play. And they love you guys, okay? Especially if you have somebody that's having a hard time breathing, or you may need help with an airway, do not ever hesitate to give them a call, okay? Absolutely excellent. You guys nailed everything on that one. Okay. So let's talk a little bit about documentation, and then we'll do our SBAR. Okay. So what are you guys going to document first?
Our assessments. Vital signs.
Vital signs
Then assessment.
and assessment. And typically, I'm not real familiar with you guys' computer charting, but are there specific places? So obviously, her vital signs you can pull off your monitor. So what are you going to chart for your assessment?
We could go into the shift assessment. And do the
Yeah,
whole
Yeah,
thing.
do the complex
Do the
assessment.
whole head to
Okay.
toe.
So
Yeah.
what is, you said, what's her heart assessment?
Irregular
Irregular
Tachycardic.
tachycardia.
with AFib.
Looking at your monitor, you can go ahead and say that she's in AFib.
Yeah.
What else goes along with your cardiac assessment? Cap refill, which was 3.
But no edema.
No edema. Excellent. Okay. Respiratory assessment, what are you guys going to chart?
Adventitious.
Bilaterally or just one side?
Bilateral.
Okay. What about her work of breathing?
It's very
Labored.
Okay. Labored.
Also crackles.
Mm-hmm. What else is she doing?
Does she have
Mm-hmm.
subcostal?
A lot of times they'll start throwing in those retractions for you, so you can chart your retractions. Is she using accessory muscles? A lot of times if they're in chronic COPD or having an exacerbation, they're really going to be pulling. You can see it. It's amazing. It almost looks like they're sucking, down to their spine to try to get enough breath in that she's that short of breath.
It also has on there where you can chart like the daughter was called and
Yeah. Who you notified.
where her head of bed is, so
Okay.
we'll put it up.
How about her, it's hard because our mannequin is not talking back to us here, but what about, do you feel like she's oriented to person, place, and time?
Yeah.
She is.
So is she exhibiting any signs of confusion? Is she, any signs of dementia, anything like that would be a good thing to be able to chart, okay? And then when you get to the point where you're going to document your physician contact, okay, and your interventions, is there a place where you guys get to chart your physician contact.
Yeah,
The bottom,
that's
yes.
the same.
It's like provider notified,
Oh,
what
yes.
time,
Okay.
what time
And
it
why
arrived,
they were
why
called.
you were-
Okay.
yeah, and any orders they gave.
Okay,
And
perfect.
you can chart like phone orders.
Like giving us
Stuff.
like a note.
Okay. And this is getting a lot better. Previously, there was just a box that you could check a lot of times that said physician notified. And this is the one thing that I harp and harp and harp on everybody about. You cannot chart provider notified. If you chart something and it leaves you asking a question, your charting is not complete. Okay? I have helped prosecute cases where the nurse charted physician notified. Well, physician notified of what? Physician notified about patient's condition. Well, that doesn't tell me anything either. Physician notified, and you have to be very specific. Dr. Jackson notified of, and then specifically what you told them. Did you say, hey, I'm really concerned about this patient? And then if you actually asked them for something, requested physician
For orders.
and if you specifically requested something that maybe you thought was appropriate and they didn't give it to you, it's okay to chart that.
So it's
Requested chest x-ray, no new orders given. Okay? You asked, the physician said no. That's perfectly acceptable charting. Okay? You're not pointing fingers, you're not accusing anybody. You're just saying, hey, do you think maybe this chest x-ray might be a good idea? Because you're on a line of thinking, maybe they're not necessarily on that same line of thinking, but you're trying to be your patient's advocate. Okay? What time, and then again, if you got any new orders. Okay? When you're charting your nursing assessments, okay, so we are going to reposition her. We're going to put oxygen on. We're going to get some IV fluids going. Okay? Let's say a half an hour goes by. What do you need to do? Reassess, and then
Chart my reassessment.
rechart. Okay? If you are doing something to fix a situation, such as this, okay, if my patient's satting 87, breathing, 26 times a minute, and her heart rate's 120, and I do all of these things, and then I don't make another note in the chart at all, that's another huge flag. Okay? So what did you do, and then did it make a difference? So in a half an hour, if you go back and you reassess, and Mrs. Young is just exactly the same, you need to keep going and try something else. Or all of a sudden, magically, you've fixed her. Well, how do you show that? You're going to recharge your vitals, you're going to recharge your assessment, because it's not just that you did these things to fix the problem, it's how you charted that you did it. Okay? And that's the huge one that lots and lots of nurses miss. Okay? And unfortunately, when you get into possibly a case situation, well, did you do this? Well, yeah. Well, did it help? Yeah, I think so. But 2 or 3 years after the fact, how are you going to know? How are you going to remember what you did? Okay? All right. So I'm going to pause one more time. We're going to get you guys ready for SBAR, and we're going to finish up talking to the doctor. Okay? I'm going to be the doctor.
okay. Where do I need to be over here?
You can be wherever you want, and you don't have to look at me if you don't want to, or you can.
I'm stand right here.
Yeah, you can stand right there and
You're
look
so
at me.
intimidating.
Like
This is
I
an
know.
intimidating
Okay.
doctor.
So we talked a little bit about SBAR because, yes, it can be very intimidating to call a doctor. Okay? Especially at 2 a.m. Anybody want to wake a doc up at 2 a.m.?
Nope.
Nope.
Not even for a Met call.
Yeah, because they are not going to be happy. All right?
Not.
However, you have to look at your patient's situation, okay? We all agree we need to call the doctor about
Yes.
Mrs. Young. Even if it's 2 a.m.?
Yeah.
Even if it's 2
Yeah, even if it's
Even if it's
2 a.m.
2 a.m.
Advocate
Okay.
for your patient.
Sometimes you can use your clinical judgment about calling a physician, okay? However, if you do have a question, you always need to call them, okay? But if it's something maybe trivial like, oh, I think they forgot to write a stool softener for her for the morning, don't call them at 2 a.m. You will never hear the end of that one,
Right.
okay?
That's real.
And And run it by, your colleagues, run it by your charge nurse. Say, hey, do you think this is an appropriate phone call to make? Okay? But if you feel like you need that physician to come in, they're not going to be happy, but guess what?
They're gonna do it.
You have to be your patient's advocate, and you have to call them, okay?
Yes.
And you're going to run the gamut of everything from, they're going to be super nice. I have worked with a physician that it did not matter what time of the day or night you called her. Oh, hey, yeah, hi. Oh, no, don't worry, don't be sorry. Didn't matter. I've got other people that I could tell they were half asleep, and I'm trying to talk to them, and they're not hearing me. I've got other people that I've called that were just darn right ticked off. Didn't matter if their patient was coding or not. They did not want to hear from you. Okay? So stand your ground. That's why filling out this lovely little SBAR thing beforehand helps. And we'll see how it goes.
Get the facts.
Get the facts and know what you need for your patient. Okay. Christina, you're up.
Okay, so I'm just gonna
Okay. I'm gonna pretend
Okay.
You have paged me.
Okay.
Okay. And I'm calling you back.
Okay.
Okay. Hi, this is Dr. Jackson. I'm returning your page.
Hi, Dr. Jackson. This is Christina. I am calling about Mrs. Young. She was seen in the ER this morning with shortness of breath and coughing up thick yellow sputum. She has a history of COPD for the past 20 years, with quitting smoking about 10 years ago. She's had increased shortness of breath with her oxygen level being 91. We've tried repositioning her.
Wait a minute. What did you say? What was her oxygen level?
91.
Okay. And what time did she get here?
She had this morning.
No. Okay.
So we are looking at some of her ABGs that had come back, and she's in respiratory acidosis, and just continuously having a hard time breathing. We've thrown oxygen on her, repositioned her, and none of that's working. So we're thinking about maybe we need to get some fluids started, because she also has a high blood pressure, and showing also some AFib on the monitor.
You said she came in for shortness of breath. Now you're telling me she's got high blood pressure?
Yeah.
Well, what is it?
It's 148/9/97.
Well, and didn't anybody do anything about that down in the ER?
Nothing was done down in the ER.
What do you mean nothing was done?
She was just brought upstairs because she was in such rough shape.
Well, those damn people down in the ER, why do they always do this to me? This is ridiculous. So what did you do again?
So we tried to reposition her and raising the head of the bed to 30 degrees and put 2 liters of oxygen on her. There was slight improvement, but she's still running low on her oxygen.
Well, what'd they do for labs?
Labs, we looked at her CBC and her electrolytes.
That's what we need.
That's what we needed. So we just did ABGs.
That's all they did?
That's all they did.
Give me a break. So they didn't do anything else?
No. So that's what I think we need to get on that. Is get some full workup. Labs, x-ray.
Yeah. Hello. All right. This is what we need to do. Bump up her oxygen. Let's get her some respiratory treatments. Let's do some Zopanex Q2 hours nebulizer treatments. Let's do a CBC. Let's do lights. Let's do another ABG. Let's get blood cultures. Let's get a sputum culture. Go ahead and start LR. Let's run that at $250 an hour for 2 hours, then drop it to $125 an hour. What's her output?
I don't know.
Okay.
She hasn't had much. She hasn't been getting up at all.
Okay. Let's put her on I&O then.
Okay.
And yeah, let's go ahead and get that chest x-ray.
And what would you like us to do about her AFib?
Well, god dang it, I can only deal with one thing at a time.
We can get an EKG. That'd be a good start. What do you think?
Yeah, I think that's a good idea. Let's
Okay.
go ahead and get a 12 lead. Get respiratory in there. See if we can't clear up her breathing here first.
Okay.
You know what? Let's give her some methylprednisone IV.
Okay.
Let's do 40 milligrams IV Q6 hours. And what was her temp?
Her temp was 99.4. So we're going to get some Tylenol for that.
We can do Tylenol 650 PRN if she needs it for
Okay.
pain or fever. And let's start some ampicillin. Let's do 2 grams IV, Q6. All right, that's it.
Okay, so we'll make sure we got all this right. So we're going to put her on I's and O's. Keep an eye on that. We're going to get a chest x-ray. EKG, we have methylprednisone IV 40 milligrams Q6 hours. Tylenol 650 PRN is needed for pain or fever. We're going to have lactate. We're going to have LR at 250 per hour for 2 hours and then 125 per hour after that. We're going to increase her O2. We're going to get a respiratory treatment with Zopanex Q 2 hours. We're going to get CBC and electrolytes, another set of ABGs, blood cultures, and a sputum culture, and also ampicillin, 2 grams IV every 6 hours. Is that correct? All that sound good?
Yes, that sounds good. Oh, actually, let's do some incentive spirometer too. And I'll be in there, maybe in about an hour to come and see her.
Okay.
But if she gets worse before then, you give me a call.
Okay, that sounds great.
All right.
Thank you so much.
That was so fast.
I'm
I was like,
I was like,
Okay. Absolutely awesome. You did great.
thanks.
Okay.
My spot was real messed up.
Okay. You guys can give me a grade. You can give her a grade. And then we'll talk about
Kelly.
Woohoo!
I just
All
had
right.
this corner.
I know.
I was like, okay,
I know.
so is that how fast it happens?
Yes.
So you need to have a paper with you and just like, because okay, see, writing it like this really messed me up. I needed to go straight down
It just goes.
I literally wrote like all
because
over the
mine
place.
is just messing out and I don't even know what I'm doing.
Exactly. And
Sometimes
a
it
lot of times, again,
Yeah.
we were thinking maybe it's 5 o'clock in the morning. Your doc may not be really awake. And they may not be listening, even though you're telling them. And I've had docs yawn on me. I think I've even had one fall asleep listening to me during
Oh
report.
gosh.
So you need to make sure that you've got your doc's attention. You gave the excellent report, okay? Just what you needed to do. You were able to have all your information right there. And you guys commented about how fast they fly off those orders to you. Because she didn't really have anything, and what you were wanting and asking, zoop, they're gonna list them. And you can tell your doc, hey, hang on.
Can you can ask them to repeat?
And what I wanted to make sure that you did, which was absolutely perfect, is before that doc gets off the phone, if you do not have a place, now I know lots of places are trying to go to the physicians putting their own orders in on the computer. We all know how in the real
LOL.
world, you as the nurse are just going to go ahead and put them in. But you need to make sure that you're putting them in correctly. So you have to read back, make sure you got down exactly what they wanted, okay? And that's the part that I was hoping that you were going to
We learned that in
automatically
Mediman. We don't do that in Mediman. They're like, what are you
do.
doing?
You got that. Awesome. You guys
Bad
did
deal.
great on that.
Good job, Christina.
Thanks.
So we are going to help Mrs. Young. She's going to be awesome. You guys hit on the whole education part. We talked about getting social work or case management involved. Education's a huge part of this because obviously there's been things that have been neglected with her. Great teaching opportunities, not just for medication, but maybe she needs somebody to come in at the home with her. Who knows?
The home health nurse come in and check on her more than once
Just
a
to
day.
kind of get her back on track. Okay. That's going to be the official end. Now, just for my own feedback, what did you guys like about the simulation?
All of it.
I liked it. Yeah,
Okay.
I think it was like a whole picture, kind of
Yeah,
idea,
it's
putting
nice
it all
to come in
together.
and see, well, not see the, like,
Right.
hear about it and then automatically your brain starts working.
Yeah.
It's also, I feel like when we do Mediman, when it's like, when we're doing it upstairs and the person's talking to you, I feel like it's almost more stressful and I make more mistakes, whereas here, got to sit, think about it, work together, and it, like, I feel like I did a really good job this time,
Yeah.
like, more than I do in Mediman upstairs.
Yeah.
And I think too, like it was very realistic because like I've typed up on the pavilion and the nurses will literally get a patient like this where Edie has done pretty much nothing and they just get her to the floor as soon as you can and it's like, okay, well, I need to get all this stuff done, and it's just really overwhelming. And I felt like
is.
this was good practice for
Yeah.
a situation.
I felt like this was really real life. Like
Mhm.
And use it
upstairs,
as
it's like
Bartley.
they trick you. Like, oh, the chest tube was just in, now it's out.
We don't-
Yeah.
You know, like here, this is real life. Like this is actually nursing. We called the doctor. The doctor actually acted like a doctor probably will act.
Yeah, that's real.
And, you know, or I'm hoping you guys don't have a lot of those, but it's definitely a
Well, it's
possibility.
good practice.
Yeah.
It is. And anything that I could have changed about this lovely scenario here.
I liked it.
I liked it a
thought
lot.
was just fine.
Okay.
Do you want to know your grade as a physician?
Oh, well, of course. No.
I didn't think you were bad.
I gave you a 6.
I gave you a 3.
You were sleeping.
Well,
through
because,
it.
I was trying to be your typical physician. So
I
the
didn't
3
think
is
you were
okay.
very polite.
I gave you.
And you're going to have most of your physicians.
But I have high standards.
I gave you a
I know.
6 because you at least gave all the orders and you listened to
Yeah.
what my opinion was because I am with the patient, not you.
Exactly.
And you asked for more information too.
Yes.
Mhm.
Yeah, I
didn't
did.
give you a bad grade because you're sleepy.
It's okay.
I can give you a bad grade because you're
The nurses
so
don't get to be sleepy.
Well, if I'm at home, I get to be sleepy.
That's true.
Well, that's
But
true.
if you're on call,
I know. All right. Well, I do have prizes for you guys.
Right.